introduce now the first speaker of this double webinar occasion, Luong Nyugen Thahn, which is a PhD student at the Department of Women's and Children's Health. And he's actually going to defend his PhD this semester, as so is Matthew. So we have now two PhD students that are nearly the end of their PhD roads. So they are going to present to us, a part of what they've been doing these past 4 years with us. And Luong is gonna talk to us about bridging the gap and how to leverage the sustainability agenda to inform policies and actions on drivers of antimicrobial resistance. So his work is more focused on the policy aspect of antimicrobial resistance. And with that, I'm going to stop sharing the flyer on my screen, and Luong, is now your time to shine on the digital stage of our webinars. Thank you so much for your attention.
Thank you so much, Eva. Let me share my screen.
Yes, we see it.
You see my screen, right?
We do, and full screen also. Yes, perfect.
Good morning, everyone. My name is Luong, PhD student at UAC. As introduced by Eva, I'm focusing on the governance of antibiotic resistance and the link with the sustainability agenda. And my presentation will have 4 parts: the introduction, the methodology of study that I have conducted, the key results, and discussion and conclusion. So first, let's talk about antibiotic or antimicrobial resistance. It's the phenomenon occur when the antibiotic is no longer work against the infections. The first antibiotic was found in 1928, as we already know, and since the 1980s, we are in the discovery void, which is that no new antibiotic class has been discovered. And it's because the inappropriate use in human and also in the animal health. And it's also usually be framed as a silent pandemic, which leading to the rapid global spread of the resistance. And AMR is the 3rd leading cause of mortality in the world, and is projected to leading to a 1% of reduction of global GDP, and it also can increase the healthcare costs, and it's also affecting to many other revenue sectors. For example, the food security, it also can be affected. So the question here to be concerned is, are we heading back to the pre-antibiotic era? So take this example. Typhoid fever is very common disease, especially in the low middle income country where the water and sanitation is the problem of concern. And in early 20th century, it was a deadly disease with very few treatment options. But when we have antibiotics, it's helped to make the disease to be controllable and preventable. But here you can also see a recent report emerging of extensive drug resistance to typhoid fever in Pakistan. The paper was just released a few months ago, and it's raising to a threat that we need to now thinking on, like, bring it as a global security level. And one common reason they found in the study is that the main reason for the spreading of infection and also the resistance is the use of contaminated water for drinking and irrigation. What's the lesson we can draw from here is that if the fighting for AMR is just focusing on prescribing the practice and also drug development, it might only treat the symptom of the problem. It's not treating the cause of the problem. And on the other note, in 2015, the WHO has issued the Global Action Plan trying to elevate the level of action in all of the country in the world. And by 2023, around 180 countries has issued their own national action plan. But the result, like the recent study, they show that the implementation of National Action Plan is not effective. And they show that in the system where the AMR is already widespread and the capacity for mitigation action is limited, the increasing of incremental approach framework trying to bring more regulation to reduce the antibiotic use or trying to invest more in the government are insufficient. Instead, we need to think to address AMR on the fundamental level. It's need of a transformation. So what is the three priorities to thinking on how we can address problem from addressing the underlying driver of the problem is first, to reduce the demand for antibiotics. Second, limit the opportunity for resistant strain to emerge. And thirdly, slow the global spread of AMR. And if we're looking at the sustainability lens, we can see that many driver AMR can be also addressed from the SDG agenda. For example, driver of AMR in the human health sector can be addressed by the SDG 1, SDG 3, or SDG 6. Driver of AMR regarding to the animal health and environmental health sector can be addressed from the achievement of SDG 13, 14, and 15, and also driver regarding to the economical and political enabler of AMR can be also addressed from the SDG 8, 9, and 17. But the main challenges is that how we can formulate and how we can implement the integrate intervention from SDG to AMR. Recent study, they show a gaps in policy formulation and implementation, which is the difficulty moving from high level framework from Global Action Plan and the SDG plan in the international level to localize adaptation and make the sustained national action is the difficult and the challenges. And it's also because the AMR currently remains largely invisible in the SDG framework. It may creating the blind spot where well-intentioned SDG action may accidentally conflict with the AMR actions. So we need to have more evidence to show that how AMR and SDG policy interact and can work together. So with that question, my PhD was conducted to answer the question, and it was based on four sub-study. And in the first study, I assessed the past action on the global level and using the secondary data from WHO, World Bank, and United Nations and track survey to understanding the trend in AMR indicator. And in the second study, I did a literature review, try to mapping the evidence regarding to the driver of AMR, what are the relation and the interaction between driver of AMR. And from that, in the third study, I chose 10 Asian and African countries as a case study and assessing the current priority to addressing AMR in their national AMR and SDG policy document. And it's leading to the fourth study where I assessing the policy interaction using the same set of data as identified from the third study. So in the first study is to evaluate the past action, and the main research question is what's the association between the national action and trend in AMR indicator. And as you can see here, I have evaluated the government action from the track survey and also collecting the data relating to the driver in the health system, the data on the use of antibiotic all around the world, the state of resistance, and also the drug resistance index. And from that, the data for AMR indicator was collected from 2000, 2016, which is before the launch of Global Action Plan. And it also has been divided into two main periods. The baseline is data from 2000 to 2008, and the follow-up, which is from 2008 to 2016. And also for the governance action data, I assessing using the annually survey. So after WHO issued the global action plan every year, country need to answer and reporting their action of the implementation of the national action plan on AMR. So I collected those data and do the assessment. And as you might guess, a country may see a trend in worsening their AMR indicator, or may see the improvement in the AMR indicator. And also a country may increasing their government action over years, or some country may also see the decreasing in the level of implementation of government actions. And from that, it was allowed me to taxonomize the country into four main categories. A country can be in the positive cycle if they are showing the increasing the increased action index, and also the reduction of the AMR indicator, but they can be also in the meeting challenges stage, where they already increased their action, but not seeing a reduction of the AMR indicator. A country can also see a reduction in the AMR indicator, although they don't have increased action. And in the worst case, the country seeing both the decrease of government action and also an increase of AMR indicator, which is worst. And in a second study, what I have said is to mapping the driver antibiotic resistance on the literature. So first I conducted a systematic literature review, and from that, using the text extraction and NLP, I was able to formulate and visualize the network of driver of AMR. And using the network analysis, it's allowed me to go beyond the linear cause effect of just like two driver to understand the more complex interaction of the whole AMR driver system. And also using the network analysis here, it's also allowed me to identify critical intervention point from identify different key important driver on the network using the distal-net index and the centrality metric. Just a note, the distal-net index is a proxy to measure causality. So it is the average distance from a driver to AMR in the causal network. So if the distal-net is low, it means that the more proximal or more direct cause of the problem. If the driver or if the distal-net index is high, it's more distal driver or more indirect cause of the problem. And in the third study, the main question is to understand how the driver of AMR is targeted in the national AMR and SDG policy. And it's the documentation analysis, and was conducted into two main steps. The first step is to do the international document level analysis. So I was assessing the overlap and the complement of the SDG agenda on the WHO Global Action Plan on AMR. And the second step is to conduct a national document level analysis. 10 countries was purposely selected, and also I had assessed the adoption of national agenda from the global agenda, as well as comparing the difference among the countries, and using content analysis and statistical analysis as an analytical framework. And in the fourth study, using the same set of policy document and country identified from the third study, I have conducted a pairwise comparison between AMR and SDG policy. So the interaction between policy was conducted on different level, at the level of objective and also implementation level, but also on different aspects, is it within a single policy domain. So assessing the objective and implementation, objective formulation and implementation of AMR and AMR policy, SDG and SDG policy, and also cross-agenda interaction between AMR and SDG policy. The interaction classification was added with the assistance from large model and validated by the human reviewer. So now moving forward to the key result of the study. So the first study has been published in the PLOS Global Public Health. If you're interested, you can have a look on the journal. I'm just going to present a very key result. So the first key result we found is that the 2016 governance action data show a negatively correlated with the AMR indicator trend from 2000 to 2016. As you can see here, that when the level of action is increasing, we see a decrease of the AMR indicator. Another observation, we also see that the level of 2016 governance action is independent, is regardless with the baseline level of the indicator, and also the monitoring and surveillance component is most commonly correlated with indicator, while we don't see the prevention component have the association with any indicators. And also, well, what also interesting is here is the probability of half reduction of the indicator, the probability. So here is the 50%. As you can see for the two lower curve, which is for the use in the purple and also for the drug resistant index in the red, in order to reduce 50% of the indicator, we need to have the level of action around 3.6 over 4, which is you need very high level just to reduce, have a chance of 50% probability reduction. For the resistant, the level of action is like around half, like 2.5 to have 50% chance of reduction. And also we see that for the driver indicator, they show high probability for the improvement irrespective, regardless of the action, but they have a slightly slower or smaller slope comparing to like with the resistant and the resistant index. And when we categorizing the country into 4 main governance syndrome, as I has presented, we found that around 3/4 of country has increased their action from 2016 to 2023. But if we have a look on the driver, almost country they are in the positive cycle, which is good, but it's very few for the resistant, the use and drug resistant index. And regarding to the use of antibiotics, both in low middle income country and high income country, they are not in a very positive scenario picture. So with that, we can see that the action on driver of AMR have a very promising, it's quite promising, and it's leading for us to conduct a second study to understanding, to mapping how the driver of AMR is currently discussed and understanding in the literature. So with that, we conduct a literature review, and we found that the evidence for distal driver currently is more fragmented than for proximal driver. So on the left figure, so that we have 47 review, and we identify 217 unique causal link between driver. And in the left figure, as you can see, the distal driver is on the right and the proximal on the left. We see that the number of paper mentioned about the distal driver is much less comparing to the proximal driver. And we see that like the minimum set of paper needed to fully characterize the distal driver is much more, but the strength of evidence for the distal driver tend to be weaker in comparison with the proximal driver. And we also found that in the literature is that the driver of AMR are not only associated with the use of antibiotic, they are mostly the proximal driver, they are also linked to the risk of spreading the resistance to access to antibiotic and the use of antibiotic. But for the distal driver, they are more broad. They are might be challenged harder to the discovery challenges. There can be environmental and socioeconomic factor, and they also can be due to the limited surveillance capacity and might be also due to many developmental issues. And in the third study, so now moving to the third study, which we have zoom in, take a case study and to assessing the national action plan to understanding what's really happening, what are the current priority targeting on the driver AMR. And first, we assessing on the international document, the document from WHO and United Nations. We see that the two agenda, they share moderate overlap, around 50%, half of the driver being shared between the two policy and the global action plan on AMR. They tend to focusing more on the driver conservation of antibiotic effectiveness and the containment of AMR spread, while the SDG agenda, they tend to targeting on the driver that are cross-cutting challenges. And here is the intersection between the AMR objective and the SDG objective at the international level. You can see that most of the intersection is around the AMR objective 2 on surveillance and research and the infection control and optimized use of antibiotics. And when assessing at the national level, we see that there is a gap in integrating the SDG into the AMR planning and implementation. Theoretically, the two policies, there are like three scenarios where the two policies can be interact. So two policies, they may share the common area where the overlapping policy can be happen, or like a country may have a set of unique driver that only targeted by the this driver but not the other, and there might be also overlooked driver and this missed policy that a driver member is not being addressed by any of the agenda. And when we assessing at the national level, what we observe is from the coverage pattern, the National Action Plan on AMR tend to mostly focusing on the proximal driver, where we see that the distal driver in the National Action Plan on AMR receive less attention, but they often addressed in the SDG agenda. And and also we see that the African country, they showing lower SDG coverage compared to Asian country. And in terms of the overlap between AMR and SDG is lower at the national level, and with the China, Thailand, Japan, and Uganda showing the highest overlap. And moving to the fourth study, currently I just have some preliminary results. We'll present just some key observation. So as you might remember, in the fourth study is looking at the close look on the not just only the alignment, the overlap between two policy, but also assessing that if the two policy, if they are implemented, there is a synergy or there might be a conflict if they are implemented on the real life. And we have assessed at the objective level. We see that within the agenda interaction, the two policy often aligned, but the cross agenda often show the variation, but they still show a high alignment with, about 70% of synergy between the objective. But when moving to the implementation level, we see that the AMR and AMR policy interactions still remain highly synergistic, except only for the case of Thailand and Kenya. And the AMR and SDG interaction slightly reduced, where we see that the SDG and SDG interaction show more reduction in synergy. And if we have a look again on the interaction between at the goal level and regardless of country, we see that at the objective level, the AMR and AMR policy remain mostly synergistic. And we also see the strong synergy between the AMR and SDG, but we also notice some conflict between the AMR and SDG policy, especially in the SDG trial regarding to the responsible consumption and production, and with the AMR objective regarding to the surveillance and infection control. And moving to the implementation level, as you can see here, there are more of the orange and the red square, which imply that the conflict policy increasing a lot during the implementation level, especially in the SDG linked to the economic growth, industry, and consumption and production. So what is the key lesson learned, and what is need to be what is the key takeaway from my presentation is, from the first study, we see that the country, they show a lot of increased action after the issue of global action plan, but the situation does not improve much. Why? It's might be an evidence of that the ambitious government action could reverse the trend, but it's easier to implement on the driver rather than at the use and the resistance level. And maybe, but on that study, we just assessing the correlation between the data indicator in the 2016 and the government action on 2016-2023. So there's misalignment between the time period here. So maybe the future study could also assessing the data for indicator from 2016-2023 and aligning with the government action to see if there is a similar pattern. And from the second study, we see that the current discourse on AMR in the literature mainly focusing on the proximal driver. And we see that the intervention on the distal driver may show promising impact, but how we can do that might be need more study to assessing the impact of intervention targeting on the distal driver. And also in the third study, we have found that like the policy, if they are not well coordinated, there can be a risk of like the driver being redundantly addressed, which is in the overlapping policy area where you see that the waste of resource can be occur. And for the driver only addressed by either only AMR or only SDG, they are narrowly focused, and they can be a source of conflicting agenda where the achievement of one agenda might come at the expense of the other, and there might be also competing results because they are not well coordinated. And we also see that there are a driver that are entirely overlooked in the AMR and SDG policy. For example, the driver regarding to the global travel and migration, which is a source of spread of AMR, but in the current national policy, there is still a blind spot of addressing that driver. So the global guidance is needed to call for the integration of AMR and SDG policy, and also the local adaptation and contextualize the intervention. So that is all about my presentation. Thanks a lot for the support from UAC, Center for Health and Sustainability, and also from Face Group, which also helping me a lot during this journey. Thanks a lot for listening, and I'm looking forward for the fruitful discussion and question from you. Thank you.
Thank you so much, Luong. Thank you. Great presentation. So nice to see so much advancement. I think I missed one paper from you on my database, so I need to add that, one of the ones from this year. Really great, comprehensive, because actually the first study that came out was your second study, right? The umbrella literature review, and it's so nice to see now how the narrative goes from study 1 to study 2, and then the 3 and the 4 that's coming up. Really interesting. Let's see if anybody has any questions. You guys can put your hands up, write in the chat, just open your mic and talk to us. But I was so some thoughts, or a thought that came up as you were presenting. I don't remember in what article it was. I think it might be on your first one, that the low and middle income countries, they are going, the indicator for antibiotic use, it seems to be going worse, right?
Yes,
Yeah.
in
And
both low middle income country and also high income country.
yeah, so in both. Okay, because I was thinking about this aspect that in low middle income countries in particular, a big of the issue regarding AMR has been the lack of access to the good antibiotics, right? Or like the antibiotics that they need. So when all these national action plans started to be implemented and the global action plans, the idea was that we increase the access to more antibiotics in those countries. And I was thinking, is that something that might be giving you that data?
Uh,
Has increased because now there is more access in those places to the antibiotics that they need.
Yeah, that might be part of the reason, but in the low income country, another source for as a driver for MRI, I think also inappropriate use. So you have increasing the access, and so it's leading to the more use, but also inappropriate use, which also, yeah.
Okay, so like with the increase in use, it's not that it's more use and it's all of it appropriate, but it's also that it's
Yeah.
together with the mis or like not properly because the policies are not there yet that they can use this exactly like they wanted to, but they are actually using them as they can, basically, right? Okay, I understand. Great. Matthew, you had a question?
Yeah, I did. Could you go just to the immediate previous slide to this one, 17, where you have the graph of the ease of implementation of some of these things?
The, uh,
Yeah, so what I was curious about is that, at least the way that I saw it, there are sort of two conclusions that you could take from this, right? Like either resources should be invested in more effectively changing the things that are easy to change, or investing extra into the things like the DRI here that really require more of a push, more like a higher stated action index to actually achieve those changes. And I guess the question is, following on from Eva's last point, do you think it's better that countries that are, they have a plan, but they're struggling to implement it properly? Is it better to kind of cover the bases, maybe not as well as they should? Or should it be like properly invest into changing some of these things that really need a push to change?
I think that it should be on both. And as you has mentioned, is also, I think is correct, is that many of the country currently, they are struggling on the implementation of MR. They have issued their own national action plan, but when you read it, it's, adapt a lot. And also, I would say that like not copy and paste, but like they just adapting from the global action plan. The objective is the same, the intervention action is the same without considering the local context, the local need, and that's that's linked to that the ineffective of the implementation, I guess. And regarding to like where the resource could be go to. So what is the main implication from this figure is that investing on the driver might be easier to have could reverse the reverse the situation, but the driver is usually being, like invisible, ignored from the current policy agenda. So that's the main implementation. But it doesn't mean that the action and investment on reversing the trend for the use, the resistant and drug resistant is not necessary. They still need, but it's highlight that in order to have a chance to reduce the trend, you need to put more action, more investment. So for the low middle income country, maybe investing on sanitation, on the addressing poverty, increasing the access might help a lot to reverse the trend, at least for driver, and also leading to the cascading impact for the other indicator as well.
Mm-hmm.
Yeah, nice. Thank you.
Very good. Thank you, Matthew. And Luong, just a quick question for you, just before we finish your presentation, because I found it, I mean, enlightening. It's the first time that I hear about it. This idea that some of the policies for SDG and AMR might have conflict, like it might be like opposite kind of thing, like you apply one thing and then the effect in the other one is negative. Could you maybe briefly explain to us or give us a couple of examples of how this might work for some of those?
Yeah, so here, first, to be clear, the assessment, either if there are synergy or conflict, is at the document level. So it's more assessing on how the objective is formulated and to be interpreted. It's not assessing on the real data.
On the results, yeah, I understand. But can you just give us some examples of how this looks like?
So, for example, I remember for a case of Ethiopia. So, like in their national action plan for SDG, they focusing a lot on like try to increasing the productivity of agriculture production, and also they implemented that they need also to have a increasing use of the not antibiotic, but the
Growth,
control and like the for the
more production of meat, for example, or something. Yeah.
So but also in their AMR action plan, they also mentioned and like state that we also want to reduce the antibiotic use. So that's you see the very like conflict because the two policy they are formulated on like by different body of organization, so they are not taken into consideration or maybe not aware about the impact of one policy to the other. So that could be an example.
Yeah, that's very nice. I think that begs, the question, like, could the institutions or the different governmental bodies that work on this somehow be able to talk to each other, right? And as you are doing, seeing what are the implications of this policy and how could potentially affect this one. So it's really cool work that you're doing, Luong. Very, very nice.
Yeah.
Any other questions that you might have? Anybody for Luong? If nothing, then I think we take